So we're going to talk about Sellar and suprasellar imaging. We're looking at Sellar Tersica basically means Turkish saddle. So there's a little Turkish saddle here, very fancy. But as you can see, there's a little, there's got high ends, which is the anterior and the posterior processes, and the pituitary fossa, which corresponds to where the rider sits. And this is, the Sellar really is like the park lane of the brain. It's a very small area, and it's got a huge number of very critical and important structures going through it. And it really, because of its hormonal contents, it's going to, affects the whole body. And you can, any sort of tumor here or any pathology here is can have catastrophic effects on the body. So it's because of the small size of the structure of the area itself and the many structures there. Technique is absolutely critical in the imaging of the Sellar. You can do CT in limited patients, for example, patients who have pacemakers or have claustrophobia. But really, the standard of care is a good quality MRI. You need very thin 2 to 3 millimeter sections. And the key is sagittal and coronal imaging. And usually we enhance these as well. And of course, if you're doing the pituitary, you need to look at the whole brain as well. So a global 1 T2 weighted image covering the entire brain should be performed. Plus you should do post contrast as well, an entire axial imaging of the brain. And for some indications, which we'll talk about later, such as the accurate detection of microadenomas, we need to do dynamic imaging as well, which means that you use serial imaging at various times to look at the enhancement curve of the lesions. So the contents, as we talked about, the boundary is the Sellar Tersica, which contains all these structures, and the pituitary gland is contained within the pituitary structures, which consists of the ventral and the posterior part. And then we have the parasellar region, which includes two paired venous sinuses on the side of the Sellar Tersica, which are the cavernous sinuses. And then we have the suprasellar system through which the infundibulum passes and the optic chiasm passes, plus you have a number of vessels, including the carotid artery and the circulovillus. And the very important structure, which we don't talk about a lot, which is the hypothalamus, which is really the kind of the prime minister of the whole area. And we'll talk about that later. And above that is the third ventricle. So as we said, the primary component is the sphenoid bone. There's a little component from the Besi occiput as well. Anteriorly, you have the tuberculum sella, posteriorly the dorsum sella, and the posterior clinoid processes. The anterior clinoid processes are lateral to the tuberculum sella and project posteriorly. The roof of the sphenoid sinuses form the floor of the sella. So again, I'll show you the images. And the other thing to look for is the dural extension, is this diaphragm sella. This is what defines the difference between the Sellar and the suprasellar region. So here's a lateral projection. And again, this is the sphenoid sinus. This is the Sellar Tersica itself, the posterior clinoid process, the anterior clinoid process, the planum sphenoidal and the tuberculum sella. And posteriorly, you have the clivus. CT now, as I said, CT is obviously better at looking at the bones than MR. So again, a coronal sagittal reconstruction with the sphenoidum, plenum sphenoidal, the tuberculum sella, the pituitary fossa itself, and the dorsum sella and the clivus. Anteriorly, you have the nasopharynx, and this is the approach which the neurosurgeon is going to use to access the sella usually. Above the sella, we have the suprasellar system, which includes the circulovillus, the optic nerves, the optic chiasm, and the hypothalamus. Just get rid of this. So here's a gross depiction. So these are the sphenoid sinuses. Within this is the pituitary gland, then the infundibular stalk, and above this is the hypothalamus. You can see the third ventricle in the midline, and laterally you have the cavernous sinuses, which contains the carotid artery and a number of cranial nerves, which we'll talk about later. So again, you can see that this is, for the surgeon, this is probably the quickest route to get into the pituitary fossa. The pituitary gland itself consists of an anterior lobe, an intermediate lobe, and a posterior lobe. Here's a diaphragmatic redistribution. So the third ventricle above, anteriorly you have the pars distalis, then the pars tubralis, and the pars intermedia, and then the posterior gland, which is the pars nervosa, which is connected through by the infundibulum with the hypothalamus. So this is a MR representation. So you can see the pituitary fossa posteriorly contains very high dense hormones. So it gives you a high signal on T1 weighted images. The anterior pituitary is isointense to the brain on the T1 weighted images. So can anybody spot anything else? Anyway, so extra marks if anybody picked up the little.
Okay, we need to, if you want to have interactive though.
जी बिल्कुल जरूर बताइए.
Yeah, so किसी फंसाते हैं ना, अदनान बताएं. Adnan Salim is a resident.
Okay. So now we have pituitary is normal है, हमने anatomy के लिए देखा है. This is the sort of anterior pituitary, the posterior pituitary, which I wanted you to show. This is the infundibular stalk. So there's one other pathology for which the scan was done. If anybody can pick it up, that's very good.
Adnan, bata diye. I know you can do it. Anybody else? Adnan, apna wo naam kar rahe. Mustafa, take a, you're a very good.
Take a stab, यार. जो भी कुछ कहते हो, ज़्यादा से ज़्यादा गलत हो जाएगा.
सब अपने ही हैं यहाँ पे.
It's an area of mammillary body के वहाँ जो है अपने hyperintensities नजर आ रही है कुछ.
ये देखिए. So what is this?
Okay, so is it a basilar artery?
This is a basilar artery.
Thrombosis?
This is a little thrombosed aneurysm at the tip of the basilar artery.
Yeah.
ठीक है जी.
See, so that's the beauty of it. Once you point it out, everything becomes very clear. So those who were thinking about not speaking, now you see it, and yeah, wow, yes.
So the obviously pons आगे, उसके आगे flow void है, which is black structure, which is black. यहाँ पे flowing blood होगा या air होगी. So air तो यहाँ पे होनी नहीं. So this is a vascular structure. So this is the basilar artery, and you've got a little thrombosed aneurysm at the perfect. चलें. So the pituitary gland, the anterior lobe, it shows intense enhancement post contrast because there's no blood-brain barrier there, and it's an extremely vascular structure. It produces growth hormone, thyroid stimulating hormone, ACTH, FSH, LH, and most importantly, prolactin, which is around 20% of the cells of the gland produce prolactin. The intermediate lobe is usually hypointense, it's avascular. And the posterior lobe, it contains, as we said, vasopressin and oxytocin, and this looks, because of its proteinaceous content, it appears as white on T1 weighted images. And this is important in a number of pathologies, which we'll discuss later. So the gland usually should have a concave upper surface. If in children under the age of 2 years, you're allowed a little convex surface. In pregnancy, you're allowed a convex surface. These are again, one of my teachers always used to say that if you have to measure something, it's not important. So anyway, these are from the literature. So you can see that these are the ballpark sizes. As you can see, it increases postpartum, it increases in pregnancy, and is slightly more in male. And with age, the size of the pituitary decreases. So this is a normal gland. Again, you can see the high signal from the posterior pituitary gland, and this has a upper convex margin, but this is acceptable postpartum. Sometimes it can be an indirect sign of a pituitary microadenoma. So the pituitary stalk is the connection between the pituitary and the hypothalamus. It lacks a blood-brain barrier, so it will show usually the same contrast enhancement as the rest of the pituitary gland. It is usually smooth. It is the maximum measurement again up to 3.25 at the top and 1.91 at the bottom. But again, if you can see something, you shouldn't really have to measure it. But if you do want to measure it, this is where you do measure it, just below the optic chiasm. So the hypothalamus, as we said, is the prime minister of this whole area. It produces a number of regulatory hormones, and it produces 2 hormones itself, and plus importantly, it produces a dopamine and somatostatin. So the hypothalamus is connected to the anterior pituitary through a number of small portal veins which run along the infundibular stalk, and it's connected directly to the posterior pituitary through the infundibular stalk. It produces all the hormones that you saw for the anterior pituitary. It produces the regulatory hormones, and the vasopressin and oxytocin are actually produced within the hypothalamus, and then they are stored in the posterior pituitary. So this is the difference between the anterior pituitary. The posterior pituitary is basically a storing receptacle, and the anterior pituitary produces these hormones under the influence of the hypothalamic regulatory factors. And dopamine, which is produced by the hypothalamus, actually inhibits the production of prolactin by the anterior pituitary. And this is, as you know, this is the sort of pleasure hormone. It's the feel-good hormone as well. So you can see the importance of the hypothalamus. Few variants: the pituitary gland may be hyperplastic, may be hyperplastic, and the posterior pituitary can frequently be ectopic. The infundibular stalk may be deviated. We sometimes take this as a sign of a microadenoma, but you can see it in up to 46% of normal patients, so it's not so important. And the position of the optic chiasm can be variable as well. So here's the case in point. This is the normal place where you can see the anterior pituitary, the high signal of the posterior pituitary. Here, this is ectopic, is lying next to the infundibular stalk. This is lying next to the hypothalamus. You can see again the high signal of the posterior pituitary lying below the optic chiasm, and sometimes it can be intrasellar as well. Another important variant which we see very commonly is the empty sella. Basically, what this happens is that the suprasellar diaphragm becomes patulous, and because there's higher pressure of the CSF superiorly, the CSF starts to herniate into the pituitary fossa. The pituitary gland may either be absent, or as in this case, you can see there's a very thin rim of normal pituitary remaining. The infundibular stalk may be pushed back. Now, these patients usually have normal functions. Sometimes you can have even microadenomas associated with empty sella. And but in sort of premenopausal women, it can be associated with pseudotumor cerebri. So what are our imaging targets? What do we want to do? So first, to know anything is abnormal, we need to know what is normal or not. So we need to look at the normal appearance of the gland. We need to look at the infundibular stalk in terms of size and the enhancement pattern. And then we need to localize the abnormality. Is it sellar? Is it suprasellar? Or is it in, both sellar and in suprasellar, or entirely suprasellar? We need to characterize the lesion. Is it solid? Is it cystic? Does it have mixed components? Is there calcification? Are there vessels within it? And finally, we need to know what is it affecting and what is the surgeon going to encounter when he's trying to remove, he or she is trying to remove this tumor. Is there invasion of the cavernous sinuses? Is there encasement of vessels? What vital structures are involved? So first, we define the gland and the sellar tasica and its, hold on, I don't know what happened there. Okay. So then we determine the epicenter of the lesion. Where is it located in relation to the diaphragm sella? If it is within the sella, is the sella itself enlarged? And once we know where we've determined where the mass is, we need to see, is it solid? Is it cystic? What is the vascularity of this lesion? Are there any calcifications? And all of this will help us to define a differential diagnosis. Now, these slides are again basically from a radiology side, but I thought this was a very good depiction of an approach to the pituitary gland. So again, here's our anatomy. This is the pituitary gland. This is the infundibular stalk. This is the optic chiasm. And this is the important structure, which is the diaphragm sella, which is basically an incomplete extension of the meningeal dura over the sellar tasica. And this is the boundary between the sellar and the suprasellar region. So the involvement of this or the displacement of this sometimes helps us in determining whether this lesion is where it is located. So we determine the epicenter, where is it located, we analyze the lesion, and we try and reach a differential diagnosis if possible. So the pituitary gland itself common pathologies, most of these are adenomas. The Rathke cells are basically from the oral epithelium, and these are seen in the pituitary and in the lymphadenopathic stalk. So any pathology which affects the pituitary can also affect the stalks. So the commonest is the adenoma, Rathke cleft cysts, and craniopharyngiomas. The pituitary stalk itself, again, contains Rathke cells. You can see Rathke cleft cysts, which are not that common, but these are the commonest tumor here, craniopharyngiomas. And in children, you can see germinomas, eosinophilic granulomas, and in adults, this is a common site for either metastasis or granulomatous disease like sarcoidosis or tuberculosis. The optic chiasm is kind of like a 8 lying on its side. And this is an extension of the brain itself. So this is glial tissue. So this is affected by gliomas. Again, adults will have different kind of gliomas. Children will have different kind of gliomas. And in the West, it may be associated, well, it may be affected by MS, and you can have tumefactive plaques here, which can mimic disease. But certainly, I've never seen one in my practice. Then, as I said, the hypothalamus is the area around the third ventricle. This is the third ventricle in the midline. This is above the optic chiasm. And this, again, as I said, is an extremely important structure. You can have gliomas here in adults. You can have hematomas in children. And again, germinomas and eosinophilic granulomas also typically seen in children. Laterally, we have the carotid arteries. This is the cavernous part, then the supracavernous part, which splits into the anterior cerebral artery and the middle cerebral artery. This is, again, you can have aneurysms in relation to this. This can be ectatic. Sometimes it can swing across to the midline and lie quite close to the optic chiasm, and you can have other anomalies. And laterally, we have 2 paired venous channels. So again, anybody wants to identify the structures? So this is the carotid artery. What is this?
Dr. Nasser, could you please read that?
So what are these 3 lateral structures?
Wait, कौन बता रहा है? I'm gonna pick some. Amar bhai.
Dr. Adnan, Dr. Amar कोई भी?
Amar.
So हमने पहले बात की थी कि इसमें 2 किस्म की चीजें जाती हैं. एक तो हमने देख ली, this is the carotid artery. So what else runs through the cavernous sinus?
सबको पता है. अदनान ने OTO डाल दिया चैप्टर में. लेकिन some people may not know what O stands for. Amar?
Okay, चलिए, let's look at the pathologies. ठीक है? हमें inflammation हो सकती है, fistula हो सकता है, और हमें schwannomas हो सकते हैं. So what does that tell you? What is running here which can give rise to a schwannoma?
ये इतने aggressive question एक drop out हो गए.
Anyway, so we move on. So we've got
trigeminal जो है.
ठीक है? So we have 4 cranial nerves which run through the cavernous sinus. ठीक है? We have the 3rd nerve, we have the 4th nerve, which you're not seeing here. Then you have the 6th nerve, which is the most medial and posterior to the pituitary fossa, and then you have the V1 and V2 segments of the 5th cranial nerve. जो V3 segment होता है वो नीचे Meckel's cave से गुजरता है. Outside this, we have the meninges. These are thicker sort of superiorly and laterally, and thinner medially and inferiorly. And इसमें, again, the commonest pathology which we see is meningioma. The second most common pathology which you see around the meninges is dural metastases in adults. And of course, they can be involved in inflammation, either tuberculosis or sarcoidosis. Below this, we have the sphenoid sinus. Again, all sinus diseases, fungal infections, mucoceles. And within the bone itself, you can have chordomas, sarcomas, metastasis, and any other inflammation. Again, we'll talk about that later. So the pituitary lesions, the most common tumor that we see is the pituitary adenoma. Rathke cleft cysts are fairly uncommon. I mean, I think I've probably seen maybe 2 in my life. And craniopharyngiomas are, again, the suprasellar or maybe suprasellar, and we'll talk about those later. So pituitary adenomas on CT, they're iso-intense to brain, they may enhance. On MR, they're usually iso-intense to gray matter on both T1 and T2 weighted sequences. They do show in contrast enhancement. Larger tumors may show necrosis or hemorrhage. And sometimes you can set asymmetric tentorial enhancement, which may reflect tumor invasion of the sinus. You can have either direct signs. Microadenomas are less than 10 millimeters. So you can either visualize it directly as a low area of hypointensity, decreased or non-enhancement, or you can have secondary signs of microadenoma. Now around MR, on non-contrast MR, you pick up around 70% of microadenomas. If you give contrast, that increases to about 85%. So 15% of microadenomas will never be picked up on MR. But the point is that you're not treating most of these present with hyperprolactinemia, and what you're treating is the hyperprolactinemia. So the point of the imaging is not really to pick up the exact intensity. I know if there are any radiologists in the audience, all of us look around, is this normal enhancement? Is this, just heterogeneous enhancement? Is this a microadenoma? So all basically, as Athar will tell you, what you want to do is to see that there is nothing there which is causing mass effect, which needs to be operated. Most microadenomas will respond to medical therapy. So secondary signs may include depression of the sellar floor, loss of the normal concavity, as we saw in that pregnant patient, or displacement of the infundibulum. But again, we can see that pregnant patients may have convex upper surfaces, and up to 46%, as we saw, may have displaced infundibulum normally. So the point of imaging the microadenoma is A, to make sure that there's no effect on anything, and B, in some patients, for example, with Cushing's disease, which won't respond to medical therapy, or in patients who have other contraindication to medical therapy, and there's a very small, about 2 millimeter microadenoma. And the other thing which you can look at is that the upper surface of the pituitary gland has become convex rather than the normal concavity which you see there. Okay? Adenomas have a slightly different pattern of enhancement as compared to the normal gland. The normal gland will peak early and then will wash out. Adenomas will have delayed enhancement as compared to the normal gland, and then they will retain contrast for a longer period than the normal gland as well. So in cases where it's important to pick up the gland, for example, if the patient has Cushing's disease or needs surgery for whatever reason, you can do dynamic imaging of the brain to pick up the adenoma. So again, here's a typical case, non-contrast imaging, very difficult to pick up anything, obviously looks homogeneous. As you start to give contrast, there's sort of the entire center part of the gland doesn't seem to be enhancing as much as the periphery. So again, difficult to pick up. But as you go on with the dynamic imaging, you can see there's a small area here which is not enhancing. And then on the equilibrium phase, the rest of the gland is enhancing homogeneously. And you can see there's a little non-enhancing microadenoma on the right side of the gland. And as time goes on, you can see this is starting to fill in with contrast. And eventually, if you scan for long enough, this will become almost the same intensity as the rest of the gland. Macroadenomas, by definition, are greater than 10 millimeters. They're around 10 to 15% of all intracranial neoplasms. And they form between 1/3 to 1/2 of sellar and suprasellar masses. The commonest abnormality is production of prolactin. And these are slow-growing tumors. Non-secretory tumors will present with visual deficits due to compression of the optic chiasm. Eventually, they may extend into the suprasellar system, they may extend into the cavernous sinuses, invade the carotid arteries, and may extend inferiorly into the sphenoid sinus as well. So here's a typical case again. The entire gland is replaced by a large tumor. You can see the convex upper surface, and you can see the suprasellar extension, and you can see inferiorly as well. It has started to scallop the inferior part of the sellar tasica. And again, this is the sinus, and this is the surgical approach. Once you remove the floor of the sellar and you make a cruciate incision in the dura, because the CSF here is at a higher pressure, this will tend to deliver the macroadenoma through into the sphenoid sinus. I think Athar will tell me if I'm talking nonsense or not, or if that's the way it happens.
Whatever you talk always is no nonsense. So
I'm glad you agree on that.
that's how I classify nonsense and nonsense. What comes from your mouth is sense. Here is no nonsense. Just be deliberate.
Good, Chelsea. I'm glad you used that. Actually, microadenomas, again, pituitary adenomas are soft tumors as compared to meningiomas, which are hard tumors. So usually they tend to become indented by the diaphragm cellar, which you can see laterally here. So this is the diaphragm cellar. This is the sella turcica. And you can see they form what is called kind of a snowman sign, which is the central constriction, which is caused by the diaphragm cellar. And this is supposed to be a fairly typical sign for pituitary microadenoma because of their soft nature. Remember, the problem is it's a small area, and the bigger the things become, the harder it is to tell where they're coming from. So you need to look for auxiliary signs such as this to suggest that this is a pituitary lesion and not a meningioma or other pathology. The surgeon also wants to know, is there carotid invasion or not? There are 3 signs to look for. First is, if you have more than 50% encirclement of the carotid artery, this is likely to represent invasion. Meningiomas, as we said, are hard tumors. They tend to constrict the carotid artery. Macroadenomas are soft tumors, so they will not constrict the artery, but they will tend to encase it. Secondly, we need to see, is there lateral displacement of the cavernous sinus? And finally, is there increased tissue between the carotid sinus and the lateral wall of the sinus? And here's an example in point. So there's a large tumor. You can see it's expanded the sella turcica. It's causing bony expansion and erosion. Superiorly, it's extended up to the third ventricle. This is the left cavernous sinus. You can see the carotid artery there, which is, you can see the tumor, the medial aspect of it. On the right side, you can see there's an increased amount of tissue between the tumor and the between the lateral wall of the lateral to the carotid artery. And you can also see that the cavernous sinus is bored outwards as compared to this side, which is straight still. So this cavernous sinus, this carotid artery is encased. The left one is not. Next pathology, which we see is fairly uncommon, are raptus cleft cysts. These are basically oral cavity ectoderm, which extends dorsally to develop into the anterior pituitary. These are very rare, maybe small, intracellular, sometimes intracellular. These are non-invasive, and these will usually not enhance, but may sometimes show peripheral wall enhancement, which can put you off and lead you to think that there may be a craniopharyngioma. These are typically hyper-intense on T1 weighted images. There are 3 things for the radiology residents, certainly there are 3 things which look hyper-intense on T1. You can have blood, you can have fat, or you can have proteinaceous fluid. So these usually contain proteinaceous contents and maybe, which accounts for the T1 hyperintensity. Because the proteinaceous fluid also has high density on CT, so this is a well-defined cystic lesion. You can see variant densities, but predominantly hyperdense. So this was a raptus cleft cyst on CT. On MR again, this is a cyst which was starting in the sellar region and extending into the suprasellar area. You can see there's layering of fluid within this. There's hyperintense fluid superiorly, hypointense fluid inferiorly. And post-contrast, there is no enhancement at all. So that's the difference between, it's got thin walls and it's not enhancing. So it's more likely to be a raptus cleft cyst than a craniopharyngioma. The other important thing is if you can see difference between the pituitary gland, which is here enhancing normally, and you can see that this lesion is entirely suprasellar. If it was a meningioma or if it was a other pathology, I would expect it to enhance. Most things in this area will enhance, but this is completely non-enhancing. So although it's not hyperintense on T1, the lack of enhancement is suggesting that this is likely to be a cystic lesion. Plus, of course, we can see that it's entirely separate from the gland itself. Pituitary apoplexy, again, is acute ischemia with hemorrhage due to lack of blood supply, presents with headache, vomiting, visual loss. Most commonly seen within adenomas, macroadenomas, which are prone to hemorrhage because of their large blood supply. Sometimes you can see this in patients who had surgery as well. And 25% of these patients will tend to have the pituitary apoplexy with all the consequences. You can have Sheehan syndrome, which is postpartum pituitary hemorrhage, secondary to hypovolemia and shock. And again, because of the age of the blood, these are heterogeneous in nature, predominantly T1 hyperintense and T2 hypointense lesions, and they will frequently contain fluid levels. Here's a case in point. This is a pituitary macroadenoma. It's extended into the right cavernous sinus. This is the pre-contrast imaging. So these are high areas of T1 signal intensity on the right and the left lateral side of this lesion. And post-contrast, you can see that the rest of the tumor is enhancing, but these foci are not enhancing. So this is blood. Again, proteinaceous fluid is possible, but this is within its location and the context, this is most likely to be blood. And you can also see this is a patient who had operated. It had a small hematoma laterally, and you can see layering of the blood due to the different methemoglobin and the deoxyhemoglobin. So these will, and on T1, you can see the high signal intensities. These are again typical appearances of blood on MR. Acquired lesions include infections, metastases, lymphoma. Tumors are usually no respecter of boundaries, so they will tend to involve adjacent structures as well. This is a metastatic colonic carcinoma. You can see it's destroyed the bone, it's involved the sella tosica, it's involved the cavernous sinus, and a benign lesion obviously would not do that. This is a slightly more difficult case. This is a patient which presented with visual symptoms. She had breast cancer. This is the normal pituitary gland. So there's a diffusely enhancing pituitary gland. Again, without the context of the disease and the presence of metastases elsewhere, it would be hard to say what this is. One hint is that, most tumors in this region, apart from craniopharyngiomas, will show diffuse homogeneous enhancement. So this is actually showing central necrosis. But again, without a history and the proper clinical context, would be very difficult to make the precise diagnosis. Another case with lung carcinoma, again, you can see the heterogeneous nature of the tumor. You can see the destruction of the clivus. You can see the involvement of the sinus as well. So this is clearly a malignant and aggressive lesion. Lymphomas, primary pituitary lymphoma is extremely rare, may be involved as part of generalized CSF lymphoma. This is usually seen at the skull base and the cavernous sinuses, more common in males in the 6th decade, maybe younger in ISO-compromised patients. So again, the characteristic of lymphoma, if you look at this, it's expanding the tosica. There's no snowman sign, but hard to say really. Could it be a microadenoma? It could certainly be. So you end up with the tissue diagnosis in the end. These are hypercellular lesions, so they usually end up with restriction of low signal intensity on diffusion. So that's sometimes a clue. And the other clue is that lymphomas will always enhance uniformly. They will never have necrosis. They will never have calcification. Pituitary abscesses are rare, maybe due to hematogenous spread, or more commonly due to direct extension from the sinus as well. May present with fever, meningitis. On MR, there will be a thick-walled cystic mass, hypointense on T1, hyperintense on T2, and they will have irregular nodular enhancing walls, and it will frequently have bony erosion as well. So here, I don't have an MR example, but this is a CT with a large pituitary abscess. You can see the thick enhancing irregular walls of this, and you can see that the abnormality is extending inferiorly into the sphenoid sinus as well. Above the suprasellar region, which is above the diaphragm cella, you have the optic chiasm, the optic nerves, the infundibulum, and the circle of Willis. And of course, we have the third ventricle and the hypothalamus. Suprasellar lesions, the most common suprasellar lesions remain extension of pituitary adenomas. So these will start from the pituitary and extend upwards. Craniopharyngiomas, meningiomas, and then we have unusual stuff, which we'll talk about later. And then we have the hematomas and other lesions which are related to the hypothalamus. So again, we'll go through some of these. Meningiomas are around 15 to 20% of intracranial tumors. Around 5 to 10% of these occur in the suprasellar region. They can arise, they can be suprasellar, parasellar, or even intrasellar. Intrasellar lesions are rare, will originate from the diaphragm cella, and these have fairly typical enhancement characteristics. They will be isointense on T1 to the gray matter. T2 is variable, but are usually also isointense. These are homogeneously solid. They will not have any necrosis. Cystic components rarely seen, can occur. Calcifications are more reported in the literature, but less seen in practice. And you will have obtuse dural margins. I'll show you a couple of examples later. And sometimes, again, this is typically reported by in the literature. You can have hyperostosis of brains, but personally, I don't see a lot of it. I don't know, Kiran, do you see a lot of hyperostosis?
Not really, sir. It's not
Not
donated.
really. Yeah, I mean, I think I can remember maybe 3 or 4 cases where you had typical hyperostosis, including one which I was shown in my exam. So again, this is again sagittal view of the brain, normal pituitary gland. There's a little. This is the clivus, and there's a little enhancing lesion. You can see the homogeneous enhancement, and you can see that the lesion has a broad base against the clivus. So this is again typical appearance of a dorsum sellar meningioma. This is a suprasellar meningioma. As we talked about, these are hard tumors. So unlike the macroadenomas, they will tend to compress the carotid artery. So you can see this is the normal caliber of the carotid artery on this side. On this side, the artery is squeezed and pinched by the extension of the tumor. And you can see on the T1, it's actually better seen, but you can also see it on the post contrast. You can see the normal pituitary gland with the concavity upwards. So this is not a sellar region. The pituitary gland is entirely normal, and this suprasellar meningioma. And again, another case, slightly more difficult. This time there is some constriction laterally. The artery is not pressed, and you can see it's homogeneous enhancement. So really, it could quite possibly well be a pituitary macroadenoma as well, and this ended up to be a surgical diagnosis. Hard to make the distinction always. As I said, the bigger things get, the harder it is to tell where they're coming from and where they're going. But if again, with the eye of faith on the pre-contrast,
yeah, sagittal would give us a better idea in this case.
Sagittal would definitely. I don't have the sagittal, but again, if you look at the pre-contrast imaging, you can see a trace of a boundary between the sellar and the lesion. So this is there's a difference here, but post-contrast, hard to make it out.
Right.
This is again a typical plenum sphenoidal vertebra, and again, this has the typical obtuse margins of extra-axial lesions. You can see the smooth interface with the rest of the brain, and you can see the inferior extension, and it is pushed down into you can see the pituitary gland, which is now inseparable from the tumor. So again, the location, the margins, and the homogeneous enhancement, this is virtually a pathognomonic appearance. Craniopharyngiomas are derived from Rathke's pouch, which we talked about. It's a benign neoplasm. These are larger than Rathke's cysts, usually are invasive and can recur. Most of these are suprasellar, but they can be intrasellar as well, or both suprasellar and intrasellar as well. They have a bimodal presentation, 5 to 15 years and 4 to 5 decades. And the pathology is also different, and I'll show you a couple of examples of this in both. So 85% are cystic. They have solid components as well. Calcifications are very common, and the cystic component again contains proteinaceous fluid and is hyperintense on T1. So if you see a suprasellar mass which is cystic, which is calcified, which is enhancing, it's most likely going to be a craniopharyngioma. So again, this is a child with a large, predominantly cystic craniopharyngioma. You can see wall calcification and you can see nodular calcifications within the tumor. इनकी जो pathology होती है, these are adamantomatous tumors, if I can pronounce that correctly. I always stumble over that. So इनका typical appearance ये होता है कि इसमें cysts ज़्यादा होती हैं और इनमें calcification hard और nodular होती है. जो adults होते हैं, these have a squamous papillary kind of tumor. So the pathology is different at the 2 age peaks. The reason for that, I don't know. But these tend to be more solid. They tend to be spherical in nature, and they will also have calcifications, but frequently not as many as you see in the pediatric variant. And again, calcifications will appear as low signal intensity on both T1 and T2 images. So another case in point, large cystic lesion, enhancing thick peripheral wall. There are no calcifications in this, but the difference between this and the Rathke's cleft cyst, which we see earlier, is A, the size and the appearance of the lesion, plus the irregular thick enhancement of the walls of the lesion. Germinomas are the most common intracranial tumor seen in children, young adults, commonly seen in the pineal gland. Suprasellar germinomas, there's no sex predilection. Pineal tumors are more common in males. On CT, they're hyperdense, strong enhancement. MR, they will again be, they are hyperdense tumors, so they will appear as dense on CT. They show diffuse homogeneous enhancement, irregular margins, and they will. Can anybody else pick up what else is happening? So this is a meningioma. What has happened?
किरण कोई है आपके gladiators में?
Abda Asra, can you just chip in, please?
पैथोलॉजी मैंने आपको बता दी है, जर्मिनोमा है, सुप्रासेलर इरेगुलर एनहांसमेंट, और क्या चीज देखने की है?
Aisha? Okay.
So it's a homogeneous enhancing area in the suprasellar location.
जी ये तो हमने बता दिया, और क्या है?
It's a nomocranium.
So it seems to be abutting the brainstem posteriorly.
जी मान लिया, बिल्कुल मान लिया, सुपर कैज़म को पकड़ा हुआ है, थर्ड वेंट्रिकल तक जा रहा है, और क्या? what else do you need to tell your surgeon or oncologist or clinician?
हमारे न्यूरोसर्जन साहब ने वो बता दिया था रिक।
Post-surgical pneumocranium.
एक तो इसकी जी सर्जरी हुई है, ठीक है, so the pneumocranium well spotted, so somebody has gone and taken tissue from it. The other thing which you need to look for is there is meningeal disease. You can see that the meninges are
Right.
thicker
So
and
yes, I can see
enhancing,
that enhancement.
and you can see
Right.
little nodules over there as well, ठीक है? So this
Okay.
has spread to the meninges as well. ठीक है, यहाँ पे भी
So
आपको
the
नजर आ रहा है, you
tumor-
can see these little nodules here and a little nodule here and some nodule back there, ठीक है? So
So,
these will tend to
Dr. Zia, is it a post-surgical rupture of the tumor? It was, or is just being
it was already there. This was done to, the surgery was done to get tissue. So this was already there.
already there. So that's important thing to look.
बायोप्सी थी, क्या हुआ था जया?
जी?
इन्होंने क्या किया था?
They just got tissue out of it. They went in, they took tissue out of it, and बाद में फिर ये सारी imaging आई थी. जी जी.
Dr. Zia, sir, specific features pointing towards germinoma?
Yeah, देखो, it is again age of the patient, younger patients, ठीक है? It's completely solid. It's enhancing diffusely, so it's not a craniopharyngioma. Meningioma इस उम्र पे कम होगा, lymphoma unlikely होगा इस age पे. So again becomes a, lymphoma can also spread. So it becomes a diagnosis of occlusion, and you can never say exclusively, imaging पे अगर आप देखो, अगर यही patient 60-70 साल का हो, तो ये चीज बिल्कुल lymphoma हो सकती है. But you have to, take the picture, and in the end, you will need to end up with tissue diagnosis. Okay, moving on to hypothalamus. Sorry.
Thank you, please.
Okay, so hypothalamic hematomas are benign tumors. They arise from the tuber cinereum, and these are usually seen in children. These patients have precocious sexual development, or they have gelastic seizures. Gelastic seizures means focal seizures and frequently bouts of laughter as well. These patients have advanced bone age due to hormonal disturbances, and you can have a number of associated congenital anomalies. So on CT, you see a non-enhancing mass in the suprasellar region. On MR, these are usually isointense to gray matter. T2 also isointense, slightly hyperintense, and most importantly, they do not enhance at all. Cystic or lipomatous components are rarely seen. And this appearance is virtually pathognomonic. I mean, it can be, I don't know of anything else but this can be. This is a sagittal T1 weighted MR image. You can see the normal pituitary gland, concave upward margin, pituitary fossa is normal. And you can see this large homogeneous mass, which is the same signal intensity at the brain. It is not enhanced at all. And this is always going to be a hematoma. It can't be anything else. So again, because despite the fact that the benign tumors, इनकी prognosis जो है वो sometimes because the size and the location and the compression of things and difficulty in getting them out, they may not have a very good prognosis. So hypothalamic chiasmatic gliomas, again, presents as a suprasellar cistern mass, T1 hyperintense, T2 hyperintense, like most things. They usually have a cystic component. They will hardly ever calcify, and they will show irregular enhancement post-contrast, and again, large irregular necrotic lesion, thick enhancing walls, internal fluid levels as well, cystic component within this. So this turned out to be a hypothalamic glioma. Optic gliomas are different disease like craniopharyngiomas, different disease in children, different disease in adults. In children, these are benign schwannomas, low-grade astrocytomas associated with NF1. In adults, these are malignant tumors. There's no association with neurofibromatosis, and they occur around the 5th to 6th decade. And these are usually anaplastic astrocytomas or GBM. And again, typical appearances, irregular enhancing mass in relation to the optic chiasm. And you can see the extension up to the optic apex on the right side. The cavernous sinuses are paired venous sinuses on the lateral side of the pituitary fossa. As we said, they contain the third nerve, the fourth nerve, and the V1 and V2 segments of the trigeminal nerve, and the sixth cranial nerve. The mandibular division of the fifth nerve passes through Meckel's curve, which is inferolateral to the cavernous sinuses. So again, here's a diaphragmatic representation. This is the carotid artery, third nerve, fourth nerve. The sixth nerve and the internal carotid artery are the medial most structures in the cavernous sinus. And inferiorly, you have the V1 and the V2 segments, and the V3 segment will pass somewhere over here. So again, this is a 3 Tesla MR image, not mine. So you can see the internal carotid artery. You can see the third nerve there. This is the sixth nerve, which is slightly medially and inferior to the internal carotid artery. And you can see the, the sixth nerve is here, and the V1 and the V2 segments inferiorly. Okay. So cavernous lesions may include meningiomas or schwannomas or metastases.
गलत लेबल हुआ हुआ था क्या? Was that MRI जो है?
जी. This is V1 where this
V1 लिखा हुआ, 60 लिखा हुआ, sorry, V1 लिखा हुआ.
V1 लिखा हुआ. So again, these are the pathologies which you see in this area. Aneurysms usually occur in relation to the internal carotid artery, sometimes to the PCOM as well. Cavernous aneurysms are 2 to 3% of all aneurysms. They're about a quarter of cavernous sinus lesions. And when they present with nerve palsies, it's usually the V1 and the third nerve which get paralyzed, and not the sixth or the fourth nerve. On CT, they present as hyperdense masses. Difficult sometimes. You can mistake them for other things if you don't give contrast, or if they're thrombosed. May have curvilinear calcifications. MR appearances are usually fairly typical. If there is no thrombosis, they will present as a flow void. If they are thrombosed, there will be heterogeneous signal, T1 hyperintense, and mixed hypointense and hyperintense T2 signal. So again, typical appearances of intracranial aneurysm in relation to the carotid artery. You can see the signal flow void. There are probably some thrombus within it, but it's predominantly a flow void. If you give contrast, it will enhance brightly. Just a single side, I'm not going to talk about this, otherwise it will take too long. Keratoconus fistula, or maybe direct, indirect, maybe post-traumatic, maybe spontaneous, will present with enlargement of the cavernous sinuses and enlargement of the superior ophthalmic veins bilaterally in this case. Tolosa-Hunt syndrome is again basically a clinical diagnosis. You have painful ophthalmoplegia due to cavernous sinus inflammation. Imaging will frequently not show you anything, but sometimes you can pick up subtle features. For example, in this case, you can see there is asymmetric enhancement, which is extending into the apex of the left orbit, but this is essentially a clinical diagnosis. Schwannomas may involve any of the cranial nerves. third, fourth, fifth, and the trigeminal or the sixth. MR, again, hyperintensity 1, hyperintensity 2, like most things. And again, like meningiomas, they will show smooth homogeneous enhancement. But unlike meningiomas, they may frequently have either cystic or necrotic or hemorrhagic components. So that may be a differential point. So this is a schwannoma in relation to the fifth nerve. And this is enhancing brightly as schwannomas do, but it's also showing cystic areas within it, which you will not see with the meningioma. And this is, in contrast, this is a fifth nerve, V3 fifth nerve neuroma. So this is passing through Meckel's cave. This is inferior and lateral. Remember, there are only two things which involve two cranial fossas. So this is involving the posterior and the middle cranial fossa. So it can either be a meningioma or it can be a schwannoma. And schwannomas are more common. Plus, you can see the large cystic component as well, which you will almost never see in a meningioma. And plus, of course, you have the typical dumbbell appearance and the location within Meckel's cave. This is just to show again. This was actually a cavernous meningioma and not a schwannoma. But again, the appearances can be very similar. But there is no cystic component. This is showing diffuse bright enhancement. Plus the other tail. What other radiological sign can we see? Anybody? meningioma का एक साइन नजर आ रहा है इसके ऊपर, कोई बताना चाहेगा?
Dural tail.
Very good, excellent, very good. So there's a little dural tail extending laterally. ठीक है?
किसने जवाब दिया ये वाला?
सर मैंने जवाब दिया.
Okay, great.
इसको भी दिया है, बस को आपको कोई कॉफी पिलानी चाहिए जी. Very good, well done, very well spotted.
Good.
Lipomas, again, very uncommon, benign, asymptomatic. If they're large, they can compress structures. Again, as we said, T1 pay, these are white. And this is a case in point. This is a small meningioma on the right side in the suprasellar area. This is a post-contrast fat suppressed T1 weighted images. You can see that this lesion has disappeared on the fat suppression and there's no enhancement at all. And this really, it can't be anything else. So this is a little lipoma, which is an incidental finding.
ये sinus wall क्यों मोटी हुई है? लग रही है ना?
जी, वो partial volume है, वो partial volume है.
Sinus wall.
This is just partial volume. You're cutting through a bit of the clivus visually.
Right. Thank you.
Okay. So infracellular regions, skull base, sphenoid bone, sphenoid sinus, nasopharynx, clivus, these are the important structures. These are the pathologies which you see. The most common are chordoma, chondrosarcoma, sometimes difficult to differentiate between them. Any of these other lesions can also involve this. Paget's disease, Pakistan, if you see it, it's something else. I've never seen Paget's in Pakistan. Chordomas arise from the primitive notochord, typically arise from the clivus. These are invasive and destructive lesions. On CT, there'll be bone destruction, there'll be calcifications. And on MR, you will have ossified fragments, calcifications, and variable enhancement. And again, irregular lesion, you can see that the clivus is completely replaced and there's a solid enhancing component superiorly. The key is to look at the signal of the clivus itself. Once this is replaced, that means it's going to be a bony lesion and not a primary intracranial lesion. And here's another case in point. This is the normal clivus marrow. This is a mucoepidermoid from the clivus. You can see that on T1 weighted images, the marrow is completely replaced. So this is abnormal. If you see replacement of the fat marrow, look for primary bone pathology. Mucoceles are uncommon in the sphenoid sinus, only 1 to 2% of all intracranial mucoceles. And again, because of their high content, these are low signal on T1. Sometimes because of protein content, it will be high signal. And again, very typical lobular features, expansion of the sinus, extension into the sphenoid sinus, telling you that this is a primary sinus lesion. Plus, they will expand the bone, they will not destroy it, so you will have a very thin bony margin laterally. Tumors, again, this is a PNET, could be anything at all, any malignant tumor which has completely destroyed the skull base, extending intracranially, and so it turned out to be a PNET, but could have been anything else. In the end, just a couple of oddities and mimics. Lymphocytic hypophysitis is an autoimmune disorder. It involves the pituitary stalk, more common in women, particularly during pregnancy and postpartum area. And the hallmark is an enlarged stalk which shows diffuse dural enhancement. So here you can see that the pituitary stalk is thickened and enhancing. And again, normal pituitary gland enhancing zigzag. But this is again, it's an important diagnosis in that if it's left untreated, it can lead to pituitary malfunction because of the destruction of the pathway between the hypothalamus and the pituitary. And if you treat it with steroids, it will respond very well. So, just something to bear in mind looking at the appearances. Maybe it's important to raise the possibility to your clinicians. Another common area in this disease is sarcoidosis, particularly in the West. We see quite a bit of sarcoidosis in this country as well, but it's usually called TB. But I think as radiologists, certainly you need to be aware of the presence of sarcoidosis. It's more common in the suprasellar region than TB is. So it can lead to cranial neuropathies and it can lead to pituitary insufficiency. And again, the hallmark is a thickened stalk, which you see there, and you can see meningeal enhancement as well. So again, the four things which typically involve both an organ and the meninges are lymphoma, TB, sarcoid, and metastases. So ये चीजें अपने आप ज़हन में रखिए जब आपको pituitary visceral disease भी नजर आए और साथ आपको meningeal disease भी नजर आए.
सर क्या बोले आपने? लिम्फोमा, टीबी,
sarcoid, and metastases. Okay. So again, this was a patient with metastatic breast cancer. Again, it could be anything else. Unless you know the history, this patient has got breast cancer, she's got metastases elsewhere. This is kind of totally, could be a number of things.
One can call it a circus also, right? I mean,
जी, बिल्कुल. Okay, जी. Final case. कोई abnormality बता दे. This was something which we saw about 3 days ago. So the very subtle. आप पहले देख लें. If anybody can tell me, I'll give you a history. But have a look first. If anybody can pick up the abnormality.
There's a lesion in the sphenoid sinus and antivolar sphenoid sinus.
Very चलो एक तो आप very good. So ये क्या लग रहा है आपको? इसकी क्या इंटेंसिटी है? ये इनहैंस नहीं किया था, कॉन्ट्रास्ट जब दिया बिल्कुल ऐसे ही रहा था. इसकी बाकी किसकी तरह लग रहा है ये?
Size and intensity लग रहा है almost.
ठीक है, looking less to the brain. So again, this is a little encephalocele. This is herniation of brain matter into the sphenoid sinus. Okay. आप बताइए और क्या abnormality है? Very well spotted. ये किसने देखा था ये?
I wouldn't have figured that out in this picture. Encephalocele.
नहीं, I'm most impressed. Very good. Or there's one other abnormality. If anybody can pick it up, otherwise I'll give you a history which will help you to pick it up.
So it's basically planum is missing, I think.
What is missing? नहीं, ये तो आपने बता दिया ना, ये तो herniation आ गई. इसके there's other. So there's one other abnormality. Well, there are two other abnormalities. अगर आप देख सकते.
I think visualize नहीं रही अच्छी orbital plate of frontal bone जो है.
उसको आप छोड़ दो, वो देख लिया हमने. आप okay, look at the pituitary gland. This patient has, I'll give you the history. This patient has excessive urination. कहते हैं जी मैं सारा वक्त पेशाब करता है.
I think they should try to recall the normal anatomy on T1.
जी बिल्कुल.
Right.
This is the hint.
No.
हमने क्या देखा? पिट्यूटरी के क्या पार्ट्स थे जी? There was an anterior part and there was a posterior part. Posterior part में क्या होता था? Oxytocin and vasopressin. Vasopressin
normal hyperintensity missing.
Normal hyperintensity is missing. So there is no posterior pituitary. This patient was involved in a roadside accident. And if you look at the infundibular stalk, you can see it's not normal. It's very thin, atrophic. You can hardly see it at all. So he had a post-traumatic injury to the infundibular stalk, which led to he's lost his communication between the hypothalamus and the posterior pituitary. So there are no stored hormones in the posterior pituitary. So this has lost its normal signal. So this patient is basically, he's had injury to the infundibular stalk, resulting in loss of posterior function and then inappropriate diuretic hormones and excessive urination, plus of course the little frontal encephalocele.
Very interesting.
ठीक है जी, this was अभी 4 दिन पहले आया था, तो मैंने कहा मैं इसको end में डाल दूं.
Yeah, this
So
was just amazing. I mean, so
fabulous.
much information you have like put it in 1 hour. That is just an amazing.
यानी जी, thank you very much for inviting me. Always a pleasure to
डॉक्टर
see
किरण
you.
कैसे
And
impress आमतौर पे डॉक्टर किरण बहुत मुश्किल से impress होती हैं.
It was beautifully narrated. Thank you so much.
thank you very much. Thank you for giving me the opportunity, and hopefully we'll do it again sometime.
इंशाल्लाह जी. Yeah.
Inshallah.
Inshallah.
Thank you जी.